Hi all. So this week's topic is healthcare services among racial ethnic groups in essence. The purpose of this lecture is to explore how healthcare services are utilized among racial and ethnic groups with an emphasis on how theory can help us better serve communities in need. So we're going to begin this lecture with a case study. Take a moment to read it here. So this is an actual case based on an article published in Annals of Emergency Medicine. I can provide the citation in this week's folder for you. Dr. Todd and his colleagues conducted a study of black and white patients who came to the emergency department with an isolated leg fracture. The study sought to determine whether there was a difference by race in the administration of pain medication for this condition. Their study found that 17% more white patients than black patients received pain medication. A few additional details about the study. The site was an urban emergency department in Atlanta, Georgia, and the authors obtained data by conducting medical records abstraction of patients seen over a nearly 3-year period. Regarding pain, there was a similar record of complaint among all patients. So here's a table representing the patient's race and medication received. Now that we've read the case study, I would like you all to brainstorm what you think are some possible explanations for these findings. Why do you think there is a disparity in the number of painkillers prescribed to black patients in comparison to their white counterparts? Go ahead and jot down some responses before moving on. We'll revisit this case toward the end of the lecture. The case study illustrated in the previous slides is a great example of a healthcare disparity. Healthcare disparities are the differences in quality of care that are not due to clinically appropriate treatment decisions or patient preferences. The graphic on the right is a visual representation of the National Healthcare Disparities Report. The National Healthcare Disparities Report is produced by a collaboration between the U.S. Department of Health and Human Services and the Agency for Healthcare Research and Quality. The National Healthcare Disparities Report tracks more than 250 healthcare process, outcome, and access measures covering a wide variety of conditions and settings. This report highlights the importance of examining quality and disparities together in order to gain a complete picture of health care. Additionally, the National Healthcare Disparities Report provides a comprehensive overview of the quality of health care received by the general U.S. population and disparities in care experienced by different racial, ethnic, and socioeconomic groups. In terms of what comprises quality of care, this includes effectiveness, safety, timeliness, patient-centeredness, that is, being respectful and responsive to patient needs, equity, and efficiency. So, based on this definition, there are a host of factors that affect healthcare disparities. These include things like access to healthcare, use of healthcare, need for services, patient preferences, quality of care, cultural appropriateness of care, and bias of healthcare professionals, to name a few. Reflecting on what you identified as some possible explanations for the difference in receipt of pain medication in the case example, do any of these factors address some of your responses? Now, let's see how some of these factors may fit within a theoretical framework. I would like to introduce you to the Anderson's behavioral model of health services use. The Anderson's behavioral model of health services use can help us better understand and discover conditions that either facilitate or impede health services utilization. This model suggests that an individual's access to and use of health services is considered to be a function of 3 types of factors: enabling, predisposing, and need factors. Enabling factors are defined as structural or material resources that can be barriers or facilitators. Predisposing factors are a patient's own inclination to use healthcare services. They are antecedents to behavior that provide rationale or motivation for the behavior. Need for healthcare factors represent the patient's perceived needs. So, let's explore some examples. Enabling factors are defined as structural or material resources that can be barriers or facilitators in seeking care. Examples of enabling factors include usual source of health care, availability of health services, access to transportation, health insurance, and ability to take sick time off work. Again, look back at your responses to the case study question. Do any of your responses represent enabling factors? Can you think of any additional enabling factors? One of the most influential enabling factors is health insurance. There are different types of health insurance, namely private, Medicare, and Medicaid. Medicare is a federal program for persons over age 65. Costs are borne in part by the insured, who pays a monthly premium, and in part by taxpayers and corporate taxes. Medicaid is a federal insurance program for low-income persons. Costs are split between the federal government and state government. What do you think are health insurance trends by race and ethnicity? This graph illustrates the racial and ethnic breakdown of adults ages 18 to 64 who were insured between January 2010 and June 2014. When looking at this graph, we see that Hispanic adults ages 18 to 64 were significantly more likely to be uninsured from January 2010 to June 2014. The percentage peaked in the second quarter of 2010 at 44.9%, then significantly decreased to 33.2% for the second quarter of 2014. All racial ethnic groups displayed a decrease from 2013 quarter 4 to 2014 quarter 2. This graph illustrates the racial and ethnic breakdown of Americans of all ages with the usual place to go for medical care in the year 2013 and between January and June of 2014. For January to June 2014, after adjustment for age and sex, the percentage of people with the usual place to go for medical care was 82.2% for Hispanics, 89.3% for whites, and 86.5% for blacks. In both years, Hispanics were less likely to have a usual place to go for medical care compared with blacks and whites. Returning to Anderson's behavioral model of health services use, predisposing factors measure a patient's inclination to use health services. Predisposing factors include provider attitudes, patient's perceptions, patient's cultural beliefs, perceived discrimination, patient's attitudes, mistrust of health care, patient's poor experiences or prior experiences, and satisfaction with care. So, recall that predisposing factors represent a patient's inclination to use healthcare services. You may think of these as attitudes and beliefs. Also, keep in mind that these can be from the patient's perspective or the clinician's. Some examples include provider attitudes, etc. Do any of these represent some of your responses to the case example? As a public health professional, bear in mind that we should consider focusing on addressing provider and system level factors. We can run the risk of victim blaming if we focus too much on trying to change patient attitudes and beliefs by forcing them to believe that their perceptions are wrong or inappropriate. This graph depicts the racial and ethnic breakdown of physicians and surgeons per 100,000 in the United States between 2006 and 2013. From 2006 to 2013, the rate of physicians and surgeons per 100,000 population was higher for Asians than for whites, blacks, and American Indians and Alaska Natives. From 2006 to 2013, the rate of physicians and surgeons per 100,000 population was higher, as I just stated, than all the other groups. Lower rates were observed in Hispanic physicians and surgeons from 2007 to 2013. These graphs provide data about parent-guardian reports of poor communication with healthcare providers between 2002 and 2012 by race, ethnicity, and income. By definition, parents who report that their child's health providers sometimes or never listened carefully, explained things carefully, showed respect for what they had to say, or spent enough time with them are considered to have poor communication. It is important to note that effective and respectful provider-patient communication is at the core of person-centered care. According to the graphs from 2002 to 2012, the percentage of children whose parents reported poor communication significantly decreased overall and among all racial, ethnic, and income groups. This is a good thing. However, it is also important to note that in almost all years, the percentage of children whose parents reported poor communication with their health providers was higher for Hispanics and Blacks compared with whites. Similarly, we see differences by income, graph 2, whereby those who were poor or low income reported more poor communication with healthcare providers, even more so than racial ethnic minorities. This is just one illustration of patient perceptions as a predisposing factor. The final category of factors that contribute to healthcare utilization are need for healthcare factors. These are a patient's perceived need for healthcare services. Some examples include patient's health status, severity of patient symptoms, and duration of patient symptoms. Do any of these examples reflect your responses to the case example? These graphs illustrate self-reported health and physical limitation status of non-elderly adults by race and ethnicity in 2014. When looking at this graph, we see that the American Indian Alaska Natives have the highest reports of fair or poor health status and physical limitation compared to other racial ethnic groups. These graphs illustrate a patient's perceived health status, which, according to the model, is a contributor to one's inclination to use healthcare services. And so, here again is a full view of Anderson's behavioral model of health services use, illustrating the relationship between enabling, predisposing, and need for healthcare factors, and how they contribute to one's utilization of healthcare. Now, let's discuss a bit about the article written by Mitchell entitled Racial and Ethnic Health Disparities in an Era of Healthcare Reform. For the assigned readings in general, it is good practice to be able to identify the primary objective and major points expressed by the authors. Not only is this an excellent way to ensure that you've gotten the major premise and resultant conclusions intended by the author, that is also good information to have to help demonstrate that you comprehend the material on the exams. That said, the main objective of this article was to review provisions within the Affordable Care Act and Healthy People 2020 objectives and their implications for the health of racial ethnic minorities. One important point is to have some working knowledge about what the Healthy People Initiative is. Healthy People outlines a comprehensive health promotion and disease prevention agenda that identifies priority health issues, sets science-based national health goals, and monitors the progress of population's health over a 10-year period. Let's discuss Healthy People for a moment. Healthy People provides science-based 10-year national objectives for improving the health of all Americans. Since its inception, the Healthy People Initiative has worked to establish benchmarks and monitor progress over time to, number 1, encourage collaborations across communities and sectors, 2, empower individuals toward making informed health decisions, and 3, measure the impact of prevention activities. The 4 goals of Healthy People 2020 are noted here. These goals help drive the objectives that are created for the myriad of health topic areas, from access to health services all the way to vision health. Do you think progress is being made, or rather, are health improvements being made? Take a moment to visit the Healthy People website, that's www.healthypeople.gov, to reaffirm what I noted, as well as to see for yourself where any progress has been made toward achieving some of the nation's health objectives. In particular, you can see the mid-course review on the Healthy People website. Now, back to the Mitchell article. Mitchell does a nice job of noting the key provisions of the Affordable Care Act, sections of Healthy People 2020, and how these initiatives impact racial ethnic healthcare disparities. The timing of this article and this lecture are quite historic, as the Affordable Care Act, as described in this article, is under fire in the legislature, and a replacement bill is being considered as I speak. Nonetheless, please review the article to note the areas highlighted in the table here as it relates to the impact on racial ethnic healthcare disparities. To round out the lecture today, let's return to the case study. Now that we have reviewed the Anderson's behavioral model of health services use, consider the explanations that you noted for the difference in administration of pain medication. Would you categorize these as enabling, predisposing, or need for healthcare factors? So, that does it for the lecture on healthcare services and related disparities. By way of conclusion, please note that there are a variety of factors that may impact healthcare services use. Anderson's behavioral model of health services use is an important framework for explaining healthcare utilization. The ACA is one means of attempting to expand healthcare coverage to reduce disparities in health service utilization. And in thinking of all this, it is important that we continue to devise solutions to address disparities in healthcare service use. Until next time.